The side effects of hormonal manipulation are varied, and they are substantial, and they affect men to different extents. It's important to discuss these side effects with men who require this kind of intervention. It will include tiredness, because the male muscle mass is partly maintained by the male hormone that they have. Any intervention that reduces the amount of the male hormones, of course, would result in some weakness in this man. There's also the loss of libido and also impotence, and various people have various degrees of response to this. People can have liver problems, particularly from the agents that are directed at interrupting the ability of the male hormone to affect prostate cancer. Hot flashes are one of the side effects that are present, and again, it can be really it can make men very miserable. Thinning of the bones is also a side effect called osteoporosis. The significance of this side effect is that the risk of fractures is increased, and having a fracture really impairs one's lifestyle. It's painful. It can result in inability to move around, to be mobile, to become dependent. So again, these are things we need to discuss with patients. Breast enlargement is one cosmetic side effect of the use of medications like this. What about patients in whom we have tried hormonal manipulation, which is relatively easy in spite of the side effects I mentioned, but in whom the prostate cancer continues to get worse? In these patients, we can try chemotherapy, which are agents that kill cells, preferably cancer cells, but also affect normal cells. They are given in a way that goes all over the body, which of course is what we want to achieve, since the prostate cancer in these patients has gone all over their body. But like I mentioned, they are reserved for advanced disease in those who have failed hormonal manipulations. There are various drugs that are used, including a medication called docetaxel. I must mention that until recently, the conventional wisdom was that prostate cancer did not respond to chemotherapy, and it was not widely applied. But in the last 10 years, benefit from the use of chemotherapy has emerged to the point where chemotherapy is sometimes added to initial therapy, but it's definitely reserved for patients who have failed hormonal manipulation. Side effects of chemotherapy include tiredness, nausea and vomiting. Low blood counts, important, because when the blood counts are low, patients are more tired. They are at risk of infections, which can put them in hospital and can be life-threatening, or they can bleed, and the bleeding can be life-threatening. They can have diarrhea, as well as numbness. Again, similar to having fractures. To have numbness and inability to feel, again, is something that affects quality of life. I will close by mentioning supportive care, which will be treatment that is directed at improving or maintaining quality of life, but is known not to at all impact the progression of disease. And this will include pain medication, generous use of pain medications for patients, the use of appetite stimulants to maintain weight, to maintain quality of life and strength, the use of medications to strengthen bone, particularly in patients who are getting other medications that is thinning their bones, the use of drugs to increase blood counts, to avoid infections and avoid bleeding, as well as focal radiation therapies given to specific areas of the body from which the patients are having symptoms.
Thank you. Seth, is there a role for primary chemotherapy or neoadjuvant chemotherapy in younger patients?
Definitely. I did mention the fact that until recently the conception was that chemotherapy was not very helpful. But now that we know that chemotherapy does improve life expectancy, even though it's a little bit in those who have advanced disease, we are encouraged, and therefore we select out patients who we believe are not well served by a traditional approach to their treatment. These are patients who are young and who have high-risk disease. High-risk disease will be defined by features that are present that suggest that the patient will end up having the cancer come back. An example would be a PSA that is high, or at surgery, the identification of disease outside the prostate. We do know that if we have no additional treatment given to these patients, they would have their disease come back. And if a patient has a life expectancy of many, many years, aside from his prostate cancer, there is definite evidence that if we do something to those patients, we improve their odds. Such patients, if we identify before surgery, such as a high PSA, we can give them chemotherapy before their surgery, or if that feature was identified at the time of surgery, they can be offered chemotherapy after surgery. I must caution, however, that this is not considered standard of care. It's something that makes sense, though we have studies, clinical trials going on now that is trying to answer the question and try to put in a quantitative fashion the extent of benefits that these patients would have.
Thank you. I would now like to remind our viewers that you can send your email questions at any time by simply clicking the MDirect Access button on your webcast page. I'll now discuss the role of surgery. Radical prostatectomy, or surgical removal of the prostate and surrounding tissues, is considered the gold standard for the treatment of localized prostate cancer. Surgical treatment of prostate cancer offers excellent local control and a reasonable expectation of cure. The goals of radical prostatectomy are to remove the prostate and the cancer. There are high cure rates for localized disease, and the other goals are to preserve urinary function and preserve erectile function. Another advantage of surgery is it offers the unique opportunity to obtain the most accurate staging by enabling complete evaluation of the prostate and surrounding tissues. There's been an evolution of surgery that was based on anatomic discovery and technical innovation. In 1982, Dr. Walsh at Johns Hopkins University and his group published a paper on the anatomic dissection for nerve-sparing radical prostatectomy. That was based on work that led to understanding of the pelvic fascial tissue planes around the prostate, the anatomy of the dorsal vein complex, and the anatomy of the sacral plexus and neurovascular bundles, which contain the nerves which are responsible for erectile function. The nerve-sparing radical prostatectomy basically decreased the morbidity of surgery markedly, and this led to the popularization of surgery as primary therapy. Technical innovations then followed. The push over the past 15 years has been toward laparoscopic surgery, minimally invasive surgery. The standard laparoscopic surgery has many technical difficulties and it has not gained widespread popularity, but the computer age has enabled software to be developed so that robot-controlled laparoscopic surgery can now be performed. The current surgical options still include standard radical retropubic prostatectomy or open surgery, conventional laparoscopic radical prostatectomy, and robot-assisted laparoscopic radical prostatectomy. The robot-assisted laparoscopic radical prostatectomy is the fastest growing method of surgical therapy. 2 years ago, it accounted for approximately 10 to 15% of radical prostatectomies performed in the United States. Over the past year, that number has risen to approximately 40% of the surgeries performed. The drawbacks of conventional laparoscopic surgery are that one has to use a two-dimensional flat image. The instruments are rigid and not mobile, and they're operated at a distance from the surgeon, creating a fulcrum effect. This decreases the ability for precision dissection because of less dexterity and therefore less control. It also is an ergonomic problem because it leads to significant surgeon fatigue. The robotic technology and endorest technology has been advanced primarily because of improvements in optics, development of binocular vision, which enables a three-dimensional view of the surgical field, which is similar to what we see in an open surgical field. The development of the robotic software also enables intuitive movement of instruments, which is similar to the movement of your hands in open surgery, as opposed to the counterintuitive movement of instruments that occurs with conventional laparoscopic surgery. And in addition, there's endowrist technology that has been developed wherein the instruments move similar to a human wrist. you see that there are 7 degrees of freedom of motion of these instruments, which reflect that similar to the human wrist.